TANE lecture series. And today I would like to introduce Dr. Sang-Geon. Dr. Sang-Geon is professor in Jeonnam University, and he has specialized in nuclear cardiology especially, and he has published numerous articles regarding the nuclear cardiology. So today, Dr. Cho will deliver us a lecture regarding nuclear cardiology. So please welcome Professor Cho. And if you have any questions or comments in between the lectures, please write down the questions in the chat, and we would have some time for the discussion. Thank you very much, and let's meet Professor Cho.
Thank you, Dr. So. It is a great honor to have a talk on the TANE COICA Lecture Series 2021. I'd like to talk about the guidelines and recent updates, which can implicate some important aspects in nuclear cardiac imaging in the clinical management of various cardiac diseases. As I can show you here, I am working in Gwangju, South Korea, and my specialty is in nuclear cardiology, and we can discuss about some important points which is recently enlightened in the field of cardiology. Okay, the first part is about coronary artery disease, and the first part of the part 1 is about the guideline updates in nuclear myocardial perfusion imaging, such as SPECT or PET. Here on this slide, I guess you are all probably very familiar to this setting, basic interpretation of nuclear perfusion imaging. Here we have two stress and rest short axis images on the top. And if we see the complete donuts like this, see these images, we can call it a normal image. And if we have a perfusion defect here, which is reverted by resting, like you can see here, then we call it a reversible perfusion defect. And the pathophysiology is myocardial ischemia or inducible ischemia. But if we have perfusion defect here, which is not reverted by resting, then we call it a fixed perfusion defect, and we call it myocardial infarction or myocardial scar. We generally recommend revascularization in patients having a significant reversible perfusion defect, which means a very significant myocardial ischemia. So this kind of practice is called perfusion or ischemia-driven PCI. This concept of ischemia-driven PCI was first proved by the FAME trial in 2009. Actually, many retrospective studies showed the value of ischemia-driven PCI, but the FAME was the first randomized clinical trial, and the invasive measurement of fractional flow reserve was used in this study. And they found that the FFR-guided PCI was significantly superior to angiographic-guided PCI. So we should evaluate the severity of myocardial ischemia in addition to the angiographic severity of focal stenosis. And what about non-invasive imaging? Here, this is a study in the United States in the year of 2003, and it was quite a large retrospective study, which included around 10,000 patients with stable chest pain. And they elegantly show that patients having more than 10% of the left ventricle involved by myocardial ischemia should be revascularized because the risk of cardiac death is exceeding that of revascularization in patients with more than 10% of the left ventricle ischemic. So this concept is now present on the ESC 2013 guidelines on stable coronary disease. And here you can see that the area of ischemia over 10% of the LV, especially for SPECT, should be considered to to refer to revascularization. However, this recommendation is not based on the randomized clinical trial. So the level of evidence is only B, which means that it can be considered for revascularization. So it is not as strong as the invasive FFR measurement when we use a SPECT or PET for the decision of revascularization. Interestingly, the cutoff for recommending revascularization is only 5% for PET, because PET has a superior image quality, sensitivity, and specificity for diagnosing functionally significant stenosis. So if you read the PET images, myocardial perfusion PET images, you can be more sensitive to detect myocardial ischemia linked to a specific coronary stenosis. Unfortunately, the things have changed, which is worse for nuclear medicine physicians. Here, in this table on the far left, these numbers stand for the pretest probability using the classical pretest probability criteria, but the actual pretest probability was not identical to the original classification of pretest probability, and the actual prevalence of myocardial ischemia is gradually decreasing. And this data is published in 2013, and the actual data is ended in 2009. So the prevalence might have further decreased to a lower level these days. And the very low prevalence of myocardial ischemia and the inaccurate calculation of pretest probability, in this context, the imaging modality with excellent negative predictive value will prevail. That is cardiac CTA. Especially in the era of 2015, some major trials were published in the New England Journal of Medicine, Lancet, or Circulation, many major cardiology journals showing the unique value of cardiac CTA, which had shown the superiority over nuclear imaging in terms of diagnostic certainty or prognosis. Representatively, the Scott-Hart trial showed the more treatment changes in the patients initially diagnosed with standard imaging modality plus cardiac CTA as compared to standard imaging modalities only. And on the original paper, which was published in 2015, there was only borderline difference of prognosis between patients with CTA and without. But in only 3 years, the 5-year follow-up data was published, and they found that the use of coronary CTA in the initial evaluation of stable chest pain was associated with significantly better outcome, better long-term outcome. So in 2013, which was before those cardiac CTA trials were published, nuclear imaging was almost always appropriate in patients with stable angina, just except for the patients with low pretest probability and interpretable ECG, for whom exercise ECG was sufficient. And cardiac CTA was considered rarely appropriate for symptomatic patients. But in only 3 years, the NICE guideline in the United Kingdom changed this policy to that very preferable for cardiac CTA. The original NICE guideline in 2010 was based on the pretest probability calculation and correlative imaging modalities according to that calculation. But in 2016, it was modified to to invariably perform cardiac CTA as the first line imaging study without calculation of pretest probability. So the two major changes in the NICE guideline include number one, no more assessment for pretest probability, and number two, cardiac CTA as the first line diagnostic imaging in angina suspected chest pain, regardless of pretest probability. But please remember, these cardiac CTA trials have some very important problems. In the perspective of nuclear physician, it seems not very just mainly because of the proportion of exercise ECG in the functional study group. The major cardiac CTA trials have competition between cardiac CTA versus functional studies. The functional studies include exercise ECG, stress echo, stress MR, as well as nuclear imaging modalities such as SPECT and PET. And here you can see that the proportion of exercise ECG is up to 85% in Scott-Hart trial. And especially the Crescent trials use the exercise ECG as the primary test, the first line test, and other functional testing modalities were performed only if exercise ECG had been not available or abnormal. However, please remember that the exercise ECG is not indicating the ischemia-related artery accurately. So the appropriate revascularization of the ischemia occurring artery and even the sensitivity and specificity is just a little bit better than guessing. So when the exercise ECG proportion is high, the functional study group's sensitivity, specificity, and the prognostic implication is probably very much impaired. So in Scott-Hart and Crescent trials, the only two trials which had shown a better prognostic outcome for cardiac CTA had very high proportion of exercise ECG or even used exercise ECG as the primary screening test. So these trials cannot conclude that cardiac CTA is significantly better or superior to other functional studies, including nuclear imaging, but probably better than exercise ECG only. So the most recent European Society of Cardiology guidelines do not recommend cardiac CTA as the first-line study. Here, they clearly describe that the stenosis is estimated to be 50 or 90% of the reference diameter on cardiac CTA are not necessarily functionally significant. So it can be not inducing myocardial ischemia, actually. So the current ESC guidelines still recommend the calculation of pretest probability and compare the clinically likelihood of significant coronary artery disease according to different imaging and non-imaging modalities. And you can see that SPECT has a very high positive predictive value. So if SPECT is abnormal, the invasive coronary angiography and PCI should be considered. And coronary CTA has an excellent negative predictive value, so it can be used to exclude the presence of coronary disease. So in that guideline, we should consider the pretest probability of specific patients, and if the pretest probability or clinically likelihood of coronary disease is very high, we can consider the use of nuclear imaging. And if the viability assessment is required, then also it also indicates the need for nuclear imaging. And if the patient is not likely to have significant coronary disease and history of CAD, and if the patient's heart rate control is considered to be controllable, then cardiac CTA can be regarded as first-line study. And if the patient is very highly likely to have significant CAD and very severe symptoms refractory to medical therapy, then direct referral to invasive coronary angiography is also an available treatment option. Recently, the Ischemia Trial was published in the NEJM in 2020. And this is the first trial which evaluated the value of non-invasive testing for myocardial ischemia in the treatment decision of invasive versus conservative strategies. Here, the first inclusion delineated over 8,000 patients with stable chest pain, and they performed cardiac CTA to delineate, to exclude the patients with unprotected left main disease or no anatomical stenosis at all, so revascularization is not an option. Then 5,000 patients were finally randomized to invasive and conservative strategies, as you can see here. And embarrassingly, they found no prognostic differences between invasive versus conservative strategies in patients with moderate to severe ischemia on non-invasive stress testings. However, the Ischemia Trial showed very slow patient enrollment, and in the middle of the patient enrollment, they decided to add exercise ECG as the initial screening test. So when the exercise ECG was positive, they were invariably classified to those having moderate to severe ischemia. So it is not very reasonable for patient classification, which is quite critical in this large scale randomized clinical trial. So if we do some sub-studies using nuclear imaging or other stress imaging studies only, the results may be different, but we should wait for more further analysis for subgroup patients. And the survival curves from the ischemia trial is quite interesting. Anyway, there was no statistically significant difference, but here you can see two crossing points in these survival curves. Of course, in the invasive strategy group, there can be some peri-procedural complications in the very early time points. So the prognosis seems to be worse for invasive strategy. But here, around 2 years after randomization, the prognosis of invasive strategy group comes lower than the curve from the conservative strategy group, and probably in the long-term follow-up, the result may be very remarkable, showing significant differences, significantly better outcome for invasive strategy. hopefully, of course. And if we want to decide treatment, medical versus revascularization, based on PET measured myocardial blood flow, we can use the myocardial blood flow reserve, which is also called MFR or CFR. Anyway, the threshold for deciding revascularization seems to be around 1.8 in this large-scale retrospective study recently published in European Heart Journal. And if the myocardial flow reserve is under 1.8, the risk the risk of overall mortality can be lowered by revascularization as compared to medical therapy only. So in this year, the American Society of Nuclear Cardiology announced an information statement about the quantification and clinical utilization of PET measured MBF, as you can see here. And the most appreciated strength of PET measured flow reserve is detecting the balanced ischemia and microvascular disease, which is not available for myocardial perfusion SPECT only. And here, the Journal of Nuclear Cardiology, which is the official journal of the ESC, are now publishing some technical papers named Technical Corner. And our institution also published a technical paper, as you can see here, which was written by our nuclear medicine technicians. And this is about the patient positioning and PET acquisition with N13 ammonia. And we use the auto injector, which is used for contrast injection, to make a bolus injection of N13 ammonia very homogeneously. And here is the syringe pump to infuse the adenosine for vasodilator stress. And here is the shield for the protection of the technician working around the scanner. And if you want to manually inject the radio tracer, you can make a specific type of lead shield like this to protect the patient's face and chest. And the other settings are just identical to the photo up here. And on the other side of the PET scanner, the vital sign monitoring is required to check the technical errors or the availability of vasodilator stress, and most importantly, monitor the side effects from the stress. So the blood pressure cuff is located in the leg of the patient, to not to interfere with the radiotracer injection or vasodilator infusion, which is performed on the patient's arms. After doing that, we can get the typical time activity curve, as you can see on the right. When we inject the radiotracer into the peripheral veins, we get the right heart blood pool images first, because it is circulated to reach the right heart first and go to the pulmonary circulation and returns to the left heart, and then goes to the aortic sinus where the coronary arteries are located, and the radiotracers travel across the coronaries and get into the myocardium and metabolically trapped in case of N13 ammonia or other mitochondrial tracers. And you can see a very acute peak in the earliest time point in the left heart blood pool, because we generally don't get the input function from the left ventricular blood pool. So here it is a very, it comes in a very acute manner and then goes out like this, and then myocardial tracer uptake occurs, and it makes a little bit obtuse peak and then make a plateau because the tracer is metabolically trapped in the myocardial cells. So if we have a very suboptimal bolus, then the blood pool curve can be obtuse. And if we please never use the saline after the radio tracer injection, because there can be multiple peaks if we do the saline clearance after the bolus injection of radio tracer. The reference values are 2.0 and 1.7 for MBF reserve. So over 2.0, we can consider it a normal perfusion, and 1.7 and 2 in between, it can be mildly abnormal and the relative risk is not very high. But if the MBFR goes down below 1.7, then it is a definitely abnormal finding and the relative risk is very high, and revascularization should be considered in those patients. If we have a perfusion defect in a specific vascular territory with the MBF reserve under 1.2, it is a very highly abnormal finding and the relative risk is very high, and it is the definite candidate for revascularization. But if there is no perfusion defect associated with that MBF reserve value, please check the technical aspect of the PET study and other things that can interfere with the accurate measurement of myocardial blood flow, such as bolus injection and stress and the patient preparation, such as medication or other caffeine-containing beverages or foods. And if there is no other technical errors, it can be also a marker of microvascular dysfunction when there is no perfusion defect. So we should not ignore the lower MBF reserve value, regardless of the presence of perfusion defect. And the MBF reserve can be very low when the resting MBF is elevated over 1.2 or 1.3. And if the resting MBF is elevated out of proportion to rate pressure product, which is the product of patient's vital signs, then the peak stress MBF itself can also be used for indicating abnormal flows versus normal. And the reference value of the stress MBF is 1.7 according to the ASNIC statement. And this kind of techniques can detect microvascular angina. Here, this is a very interesting set of images. On the left side, this is the what doctors see when they do some invasive coronary angiogram or cardiac CT or MR angiography, the anatomical images. But there are much more microvessels which travels into the myocardium and that we cannot see on anatomical images. And these microvessels are the major flow limiting vessels actually. So a recent trial, namely CORMICA trial, randomized 151 patients who had anginal chest pain but no obstructive stenosis on coronary angiography. So they were considered to have microvascular angina. And they were randomized to intervention or control groups. And then the prognosis, the quality of life was compared. And for the intervention group, the coronary functional testing was announced to the referring physicians, and the referring physicians stratified their medical therapy according to the functional study results. And for the control group, the functional testing was performed, but the results were blinded to the referring physicians, and the medications just followed the standard care defined the current guidelines. And it was very clearly showing the positive effect on patients' quality of life when the microvascular dysfunction affected the treatment stratification. Here you can see that all the markers of quality of life, angina severity, quality of life, illness perception, and global treatment satisfaction all the markers were significantly better for interventional groups. So the detection of microvascular angina can affect the patient's prognosis in terms of quality of life and symptom severity. Okay, another topic is about the chronic total occlusion, which can be abbreviated CTO in short. And the CTO is generally defined as the native coronary artery with absent or minimal antegrade flow, generally TIMI flow 0 to 1, and it should be it should be aged more than 12 weeks, and its prevalence is quite high, about 18 to 35% among patients referred for invasive angiography. And due to the technical difficulty of revascularization of CTO, CABG is 3 times more frequently performed than PCI, and the PCI success rate is only 50 to 70%. And the complication rate is very high, and it can be very fatal because when the interventionists are trying to pass their guide wires into the distal segment, it can perforate the coronary artery itself, and it can even be a table death. So anyway, the PCI CTO, if the PCI is successful, the prognosis can be improved, but the routine revascularization failed to show prognostic gain in patients with CTO. Here, these are the randomized clinical trials on CTO PCI, and there was never prognostic gain when the PCO revascularization was routinely performed. So we should selectively suggest revascularization for CTO in a specific group of patients. Then what kinds of patients? According to the European American guidelines, there should be significant ischemia, which is defined as more than 10% of the left ventricle. This is the identical cutoff for a stable chest pain. And if the CTO supplying myocardial segment is dysfunctional, showing dyskinesia, akinesia, then viability should be present. And another thing, if there is unsuitable anatomy for PCI, then CABG should be considered. So if the cardiologist want to perform PCI, the anatomy should be suitable for guide wire passage. So this is the decision tree of CTO treatment. And if the CTO is symptomatic, then CTO revascularization can be indicated even in the absence of wall motion abnormality or hypokinesia. And if the CTO territory is akinetic or dyskinetic, viability should be assessed using FDG PET or other myocardial perfusion SPECT or cardiac MR. And then if the territory is viable, then revascularization indicated, and if not, medical therapy is indicated. And if the patient is not symptomatic, the ischemic burden should be evaluated. And if the ischemic burden is over 10%, then CTO revascularization is indicated. So we should consider 2 things at the same time: ischemic burden and viability, when we encounter the patients with CTO, and and if they are referred for nuclear imaging. Okay, the second topic is about the viability testing in ischemic cardiomyopathy or ischemic heart failure. Coronary artery disease contributes to about 1/3 of heart failure. And the definition of ischemic heart failure or ischemic cardiomyopathy, ICMP in short, is left ventricular dysfunction that results or that probably results from coronary artery disease. So the LV ejection fraction is lower than 35 or 48%, and there should be a high-risk finding of coronary artery disease, such as very high-risk coronary angiography, or very significant ischemia or very large burden of myocardial infarct on myocardial perfusion imaging, PET or SPECT. And please remember that myocardial viability is not a biological term, but a technical term. It is not about the presence, the actual presence of histologically viable myocardial cells in the myocardial infarct zone. It is about the functional improvement after revascularization. So technically, the cardiologists want to know that if their revascularization, PCI or CABG, would bring the functional improvement of a specific myocardial segment. So that's why imaging tools are needed to assess the myocardial viability. So this is the list of the two important questions when we see decreased LV function, as previously defined, LV ejection fraction under 35 or 40% on myocardial perfusion SPECT or PET, then first of all, we should think about whether the heart failure results from coronary disease. Then we should assess the myocardial perfusion, and we can decide whether this case is ICMP or non-ischemic CMP. And if the patient is considered to have ICMP, then we should think about myocardial viability. And the question is whether the heart failure will improve by revascularization or not. So we should decide revascularization or medical treatment according to the presence of myocardial viability. So the concept of perfusion metabolism mismatch is commonly used for the decision of myocardial viability. This is the conceptual diagram showing the change of myocardial metabolism by the gradually decreasing perfusion. Here, as the perfusion goes down, the function is decreased after a certain point of hypoperfusion. And on the lower graph, actually on a normal state, the major energy substrates of the myocardium is fatty acid. The fatty acid oxidation is the major source of ATP production, and it needs much more oxygen than glucose metabolism, because the myocardium should cut the long fatty acid chain into a short fatty acid materials using much oxygen, repeatedly cutting the chains. So if the myocardium falls into the hypoxic state, there may be insufficient oxygen to cut all the fatty acid chain, and the myocardium begins to prefer glucose to fatty acid. So the metabolic shifting occurs as the perfusion and the oxygen content goes down, and the glucose metabolism is the last metabolism that remains before the myocardium becomes a scar. So even in the presence of infarcted myocardium, as you can see here on the resting and 13 ammonia PET images, there can be still preserved glucose uptake because the myocardial metabolism is shifted to glucose oxidation or anaerobic glycolysis. But if the glucose metabolism is also impaired, then the myocardium can be considered non-viable. So if the perfusion and metabolism is mismatched, then it can be considered to be viable, but the perfusion and metabolism is matched, commonly impaired, then it can be considered as a non-viable myocardium. In the earlier studies, the viability testing was the key to decide revascularization in patients with ICMP. This is a meta-analysis of 24 observational studies, including over 3,000 patients, which was published in 2002, and it clearly showed that in the presence of viable myocardium, revascularization was associated with 5 times better outcome as compared to medical therapy. So the point is, if the patient have viable myocardium, then do not leave it unrevascularized, but do the revascularization to improve the patient's prognosis. So we have to detect the presence of viable myocardium and aggressively revascularize the infarct-related artery in such cases. So it makes sense. The myocardium is viable, so we revascularize the vessel, and the function comes back, and the prognosis can be improved in such patients. However, it did not work in the following randomized clinical trials, beginning with the Part 2 trial, as you can see here. In this trial, the patients were randomized to standard arm and PET arm, and the standard arm did not receive FDG PET for viability testing. And in the PET arm, the patients received FDG PET for viability testing. And they found no significant differences in the prognosis of those between the two groups, but the cardiac death was significantly lower for PET arm. But the primary outcome was the composite event. So the Part 2 trial is currently considered as a negative trial, despite the difference in the cardiac death. So the Part 2 trial investigators subclassified the PET arm patients into adhere and non-adhere arms. Because in the PET arm, the referring physicians did not strictly follow the recommendations from the PET, and frequent revascularization was found for non-viable ICMPs, and medical treatment was also unexpectedly done for those having viable myocardium. So they excluded the non-adhere arm, and they again compared the prognosis between standard arm and PET adhere arm, and they found significantly better outcome for PET adhere arm. Although the Part 2 trial is now considered as a negative trial, this graph shows that the following recommendations from viability imaging is very important in the patient's prognosis. And the 5-year follow-up of the Part 2 trial patients also showed the same results, showing that the PET adhere group showed it was associated with significantly better outcome as compared to a standard arm without viability testing. But another trial, STITCH trial, failed to show the significantly better outcome for revascularization for viable myocardium. Here, this is the long-term follow-up of the STITCH trial, and they found that CABG was associated with significantly better outcome as compared to medical therapy alone when ICMP was diagnosed. Here you can again see the very interesting crossing points of cardiology trials comparing medical and invasive strategies. Here, in the patients who received CABG, the initial peri-surgical complications make the incidence of cardiac events in the very early time point, but it crosses around 2 years after randomization, and the CABG group goes parallelly downwards to the medical therapy curve, and the prognosis was significantly better for CABG. However, unfortunately, there was no definite interaction between the presence of viable myocardium and treatment mode, CABG versus medical therapy. LV ejection fraction improvement was observed in only those with viable myocardium, but it was not associated with mortality. So, and also the LV ejection fraction improvement was not different between CABG versus medical therapy when there was viable myocardium. So the viability testing could not prove its value in terms of LV ejection fraction improvement or the patient's prognosis. So some investigators further analyzed the interaction between LV remodeling and viability and treatment options, and there was no interaction between myocardial viability and the degree of LV remodeling and the presence and the treatment options. So until now, the non-randomized clinical trials show that the PCI or CABG is better for ICMP patients having viable myocardium. But in the randomized clinical trials, the viability testing didn't work for treatment decision in ICMP. So the current guidelines, current European guidelines recommend non-invasive stress imaging, CMR, stress echo, SPECT, and PET, that these can be considered for the assessment of myocardial ischemia and viability in patients with ICMP, but the strength of recommendation is only 2B, which is defined as may be considered. So it is not a mandatory option for ICMP patients. So, and it is not based on the strong evidence from the randomized clinical trial, but only observational studies show the value of viability testing. So the level of evidence is only B. So we can recommend a viability testing in patients with ICMP, but it is not a forceful recommendation or some mandation in such patients. So the most recent American Heart Association statement, it is described that the ICMP is at high risk for cardiovascular events. So myocardial revascularization may provide benefits to selected high-risk patients with multivessel CAD and LV dysfunction. And functional recovery after revascularization is more likely to be observed in myocardial segments that demonstrate viability regardless of the imaging modality. So the functional improvement may not be linked with patient's prognosis, but myocardial viability testing still makes sense in a scientific view, and it can be used in selected high-risk patients. Okay, the third part is about the perioperative risk stratification. And Dr. Salk, should I take a rest for 10 minutes before we begin on 1 p.m.?
Yeah, we can have 10-minute break. And I think, is there any questions or comments for the first part of the lectures? Yeah, I think if not, let's take a 10-minute break and meet again after 10 minutes. Thank you very much.
Okay, thank you.
I think it's time. And before starting the next part, by Professor Cho, I would like to announce that we really appreciate if every participant make a comments for our and we have put a link of our questionnaires. So please fill out the questionnaires, and I think we might upgrade the lecture contents or the materials. So please participate on the questionnaire and the link. Okay, so let's again meet Professor Cho. Thank you.
Thank you, Dr. So. Okay, we'll go on with the perioperative risk stratification. All right. Actually, perioperative risk evaluation is needed for the preparation of non-cardiac surgery. According to the review article in 2015, here you can see that the incidence of cardiovascular complication within the first 30 days after surgery is considered to come beyond I'm sorry, beyond 10 million cases per year worldwide. And it is considered to the perioperative death is the third leading cause of death in the United States. And the cardiovascular complication is probably at least contributing to at least 1/3 of all the perioperative deaths. Why this happens? Here, due to the surgery and anesthesia, the cardiac and cardiopulmonary sympathetic nervous system is stimulated due to the hypercoagulability, bleeding, inflammation, hypotension, tachycardia, and hypothermia, which are inevitable for patients undergoing surgery. So these type of stimulations can induce the patient's cardiac complication, especially for those having high risk factors before surgery. So in the 2014 European and American Society regarding cardiology and anesthesiology published the clinical guidelines for the cardiovascular risk assessment and management in non-cardiac surgeries. And the clinical risk models are commonly recommended for the calculation of preoperative risk using some very simple and robust clinical risk factors and markers. And representatively, the RCRI on the left and ESC on the right side, these are very widely used clinical risk calculators, and they even have web calculators which are quite easily utilizable. And both the European and American guidelines recommend to use these types of risk calculations in patients undergoing non-cardiac operations. These clinical risk models are quite simple, practical, and relevant, so very easy to use using some very available clinical markers, but they tend to underestimate the actual risk in patients undergoing high-risk surgery. Then, there is a question, how long should we wait after coronary stenting? That means the surgery should be postponed if we do the coronary stenting first and have a very safe surgery without complications related to coronary stenting. So here on the graphs, at the time point of 6 months after coronary stenting, the risk the risk of cardiac event goes down to the normal level equal to the patients who did not receive coronary stenting. So if we do the coronary stenting first, then the surgery should be postponed by at least 6 months, delaying the appropriate treatment of the patient's major problem, which needs surgery. So some imaging modalities are used for preoperative risk evaluation, and here cardiac CTA was also used for the calculation of perioperative risk, and it was found that cardiac CTA can significantly stratify the patient's risk, but there was a tendency of overestimation of actual perioperative risk in the plaque imaging by coronary CTA. It is considered that the perioperative myocardial infarction is not resulting from high-risk plaque or thrombus rupture, but from the supply-demand imbalance. So in this pathologic characteristic table, it was found that in the autopsy of the fatal perioperative MI patients, that the plaque rupture or acute thrombus was only 35% of all the cases, so that we have to focus on the supply-demand imbalance and the cardiac complications following the sympathetic nervous system stimulation by the surgery and anesthesia. Then what preventive treatment can be done? It is not clear. If we do the preventive revascularization in patients with high risk, it does not lower the rate of cardiac death or overall mortality following non-cardiac surgery. So routine revascularization is not indicated. So we have to do revascularization in selected patients according to the guidelines. So if the patient is considered to be stable, then prophylactic routine PCI should not be done because it is contraindicated. So we have to follow the stable coronary disease guidelines. So we have to assess the degree of myocardial ischemia, and the priority of PCI versus the planned surgery to lower the risk patient by patient. What about the patients showing nonnasty elevation acute coronary syndrome? It is also consistent with the current guidelines. So we need to consider the urgent or ischemia-driven PCI, and we have to decide whether the revascularization should be performed before surgery, delaying the surgical treatment of the main disease. So this is the approach algorithm tree, which is available on the American guidelines. So if the patient's perioperative risk calculation indicates a higher risk for specific patients, then we need to assess the functional capacity. If the patient's functional capacity is preserved, then we can proceed to surgery without further testing. Of course, there can be some caution for anesthesia and patient monitoring during surgery, but no further testing is indicated. But if the patient has very low functional capacity under 4 METs, or it is not available for functional capacity assessment because of some traumatic patients or the knee surgery who cannot walk or run, then we can do the further studies assessing the degree of myocardial ischemia, such as myocardial perfusion spectral PET. And if the stress testing result is abnormal, then coronary revascularization can be considered according to the clinical guidelines, as I just showed on the previous slides. So in short, If the patient has intermediate to high clinical risk and low or unknown functional capacity, and if there is possibility of changes in clinical decision-making, then ischemia testing using SPECT or PET can be performed in patients undergoing non-cardiac surgery. Then what should be done for patients showing heart failure? In case of heart failure, the treatment and the accurate diagnosis and the treatment for heart failure is the first option before the surgery, because in patients showing heart failure, the 30-day post-op mortality rate reaches up to 9.3% for non-ischemic heart failure and 9.2% for ischemic heart failure. So 1/10 of the patients can be dead in 30 days after surgery. So heart failure treatment therapy should come first in those patients. So here, as you can see here in this red box, the patient showing heart failure who is under the patients with newly diagnosed heart failure, the at least 3 months of heart failure should be coming first before surgery. So in these cases, we can guide the diagnosis and treatment using myocardial perfusion imaging or FDG PET to decide whether the patient has ICMP or non-ischemic CMP, and whether to revascularize or not. Now we'll move on to the second part of non-coronary disease. And the first disease entity is infective endocarditis. Very interestingly, the diagnostic criteria in history of infective endocarditis diagnosis has changed parallel to the developments in the imaging modality. In 1981, the von Rhein criteria needed anatopathological data to diagnose infective endocarditis. The anatopathological data means the pathological evaluation of the valve vegetation itself, or infective emboli, which can be observed in peripheral vessels. So it definitely needed biopsy of the infected material. But as the two-dimensional echocardiography developed in 1994, the Duke criteria included the 2D echo findings in their criteria list, and the vegetation visualized on echocardiography has been settled as the major criterion in the diagnosis of IE. And in the era of 2000, the modified Duke criteria, thanks to the development in the transophthalmic echocardiography, the criteria was modified, and the diagnostic category is classified to definite, possible, rejected. And this had been the most widely used diagnostic criteria until it was modified the European Society of Cardiology in 2015. However, the modified Duke criteria had limited sensitivity, especially for prospective prosthetic valve endocarditis and device infection. And another problem is that in case of prosthetic valve endocarditis, the surgical treatment may be more beneficial than medical treatment using just using antibiotics. This is the result from a recent meta-analysis, which was performed in 2017, and it consistently shows that surgical treatment is better than medical treatment in the patients with definite prosthetic valve endocarditis, with regardless of the risk model. So in 2015, the European Society of cardiology made revision for their guidelines. So the guideline revision was based on number one, clinical trials on surgical treatment of prosthetic valve endocarditis and the developments in nuclear imaging. And it is clearly described in the preamble, and especially for the FDG PET and leukocyte SPECT CT. And number three, incremental need for multidisciplinary approach. So you can see that these guidelines had the participations of different societies such as ESC, EACTS, and EANM. So when can we use nuclear imaging in the diagnosis of IE? Here, we first apply the modified Duke criteria as we have done so far. And if we have definite IE diagnosis or rejected IE without low clinical suspicion, there is no need to proceed to further testing. But if the diagnostic category reaches possible or rejected IE with high clinical suspicion, and if the valve is prosthetic valve, then we can get some more information from further image testing, including repeated echocardiography and cardiac CTA and embolic imaging and nuclear imaging, including FDG PET and WBC SPECT CT. And then the ESC diagnostic criteria can be applied, and we recategorize the diagnosis into definite, possible, and rejected IE. So on the left side is the table from the modified Duke criteria. Here, the red box indicates the criteria for possible IE, and in short, it is either culture or echovegetation positive, but no other major criterion positive, or several minor criteria are present, but when there is no major criterion positive. So this is a very equivocal finding for diagnosing infective endocarditis. So on the right side is the detailed items from the modified Duke criteria. And in the revised ESC criteria 2015, the positive finding for nuclear imaging has become the major criterion to diagnose imaging positive for infective endocarditis. Then which modality should we use, FDG PET or WBC SPECT CT? FDG PET is quite sensitive, but it can show some false positive findings. So the specificity is not as good as its sensitivity. And in contrast, the WBC scan is quite specific for infection, differentiating infection from non-specific inflammation, but its sensitivity is not as good as that of FDG PET. So if we want to screen the patients for metastatic infection or other embolic sores in many parts of the body, we can use the FDG PET, but there can be some false positive result when the scanning is performed within 2 or 3 months after surgery. And WBC scan can be used for a specific definition of the infection, which need differentiation from non-specific inflammation, such as postoperative changes. So the current guidelines recommend that FDG PET not be performed before 3 months after surgery. And then the WBC SPECT CT can be considered as an available replacement for FDG PET. Here's the actual case from our institution. 73-year-old gentleman who complained of left chest pain, which began 2 days ago. And he was he had been admitted to a local hospital for his recent acute stroke, which involved right corpus callosum and both cerebral gray matter, which is now considered probably infectious emboli, and he had received mitral valve replacement due to severe mitral regurgitation about 8 years before admission. Here on the chest X-ray, you can see that there is a prosthetic valve in the mitral valve, and there's the evidence of the sternotomy. And on the 2D echocardiography, that the valve vegetation was very equivocal, and here actually the oscillating mass comes up and goes away as the heart beats, but it was not even clear whether it was vegetation or not. So he was referred for F18 FDG PET, and this is the MIP images. And here at the middle of the heart, you can see a focal uptake measuring 4.1 SUV max, which was increased to 4.8 on 2-hour images. And on the transaxial images, it was located in the prosthetic mitral valve, as you can see here, indicated by the yellow arrow. And on the coronal images, you can see that this uptake correlates with the anatomical location, which was shown on echocardiography. So the image interpretation for FDG PET should be referred for some guidelines, because there can be some non-specific post-operative changes, and especially when the FDG PET was performed within 3 months after surgery. So in terms of differentiation between real infection and inflammation, the intensity is more intense for infection, and the distribution is heterogeneous and focal for infection, but the postoperative change can show a mild grade of homogeneous and diffuse uptake around the prosthetic valve, and especially at the tube suture and adhesive material. Here on the right upper image, you can see the conceptual picture for aortic valve replacement, and the adhesive materials and post-op peri-tube suture areas are here, so it can be a little bit separate from the valve itself. And the real infection shows intense heterogeneous uptake, and it is located in the prosthetic valve itself. And actually, this guideline say that this kinds of differences in the uptake location, but based on my short experience in the infection imaging of with FDG PET, it is quite difficult to differentiate the prosthetic uptake and periprosthetic uptake on FDG PET, because there can be some cardiac motions, respiratory motions, and some mismatches between the PET and CT images. So please refer to the intensity and distribution when you have to differentiate post-operative changes from actual infection. So the representative images show the focal and heterogeneous intense uptake for real infective endocarditis cases, in contrast to homogeneous diffuse ring-like uptake, which can be seen in non-specific post-operative inflammation. The second disease entity is cardiac amyloidosis. Amyloidosis is a protein misfolding disease, and the misfolded protein is aggregated, forming oligomeric fibril and aggregated in steps, and they are accumulated in various organs. It can be accumulated in any part of the body, and especially when it involve the heart, it can be life-threatening, occurring some restrictive type of cardiomyopathy. It is quite striking when we meet the data in 2015, when the patient should wait for even 2 or 3 years for the final diagnosis of cardiac amyloidosis in more than 20% of patients, and they should meet 4 or more than 5 doctors to get the final diagnosis in more than half of the cases. And the specialty of diagnosing physician is also very variable, and many of the patients meet hematologist or oncologist than the cardiologist for the final diagnosis. So it is a quite difficult disease entity to diagnose in the clinical fields and initiate the early treatment before the disease progresses. It takes years, it takes many doctors, and it takes many specialties as well. Cardiac amyloidosis is observed in up to 80%, so it is not rare among systemic AL amyloidosis. Cardiac involvement is the major cause of death in systemic amyloidosis, and there are 2 major subtypes which have completely different prognosis and different treatment options. They are classified according to the protein which is accumulated. So the first one is AL type, which is caused by the accumulation of immunoglobulin light chain, and the other is ATTR type, which is caused by the accumulation of amyloid fibrils made of transthyretin. AL-type cardiac amyloidosis progresses rapidly, and it has much poorer prognosis as compared to the ATTR type. And the main pathophysiology of AL cardiac amyloidosis is the plasma cell dyscrasia. So it has many things in common with multiple myeloma, and the treatment target is the CD20 positive B cells, such as chemotherapy, using rituximab. And ATTR type is further classified into wild type and mutated type according to the presence of gene mutation. And so when we diagnose ATTR type cardiac amyloidosis, gene study and further familial screening may be needed in patients with ATTR mutated type. Among them, transthyretin cardiac amyloidosis was the major target of nuclear imaging, and it has been recently integrated into clinical guidelines using bone scintigraphy for diagnosing this type of cardiac amyloidosis. And the transthyretin TTR is produced in the liver, and it was formerly known as prealbumin. The role of TTR is transporting T4 hormone with other protein materials, and 95% of TTR is present in the circulation as unbound form and free tetramer. But when the TTR is unstabilized, it can be broken into smaller oligomers, and then they can be misfolded and can form amyloid fibrils, which are accumulated in the peripheral nerves or the heart. And the tafamidis is a medicine that can stabilize the TTR tetramer, preventing its breakage into the oligomers, which can form amyloid fibrils. So, and the tafamidis treatment recently showed significantly different prognostic outcomes in patients with with proved TTR type cardiac amyloidosis. So we now have an effective treatment for TTR type cardiac amyloidosis. So the accurate diagnosis is important to initialize the medical treatment for those patients. Bone scintigraphy can be used for the diagnosis of TTR cardiac amyloidosis, and technetium DPD can be used for such imaging. And here on the left side, the TTR type cardiac amyloidosis shows a very high cardiac uptake as compared to AL type cardiac amyloid and control who had no definite heart uptake. And interestingly, the soft tissue uptake was elevated in the AL type cardiac amyloidosis as well as TTR type. So soft tissue uptake increase can be a pathological marker for diagnosing cardiac amyloidosis regardless of the subtype. Technetium pyrophosphate can be also used for TTR type cardiac amyloidosis. And here we draw a circular region of interest on the heart to include the heart contour on the left side, and we mirror it onto the contralateral chest, not to with caution not to include some bony structures around in the same size. And then we divide the mean count of the heart with the mean count of the contralateral lung. And then we can measure the heart to contralateral lung ratio, HCL ratio. And if the ratio exceeds 1.5, we can very accurately differentiate ATTR versus AEL cardiac amyloid. So in this meta-analysis, the differentiation between ATTR versus AEL cardiac amyloidosis, bone scintigraphy yielded very homogeneous and very excellent accuracy, over 90%, in contrast to cardiac MRI, which yielded only very heterogeneous and very low, even low diagnostic accuracy. So now the clinical diagnosis criteria includes the use of bone scintigraphy and grade 2 or 3 myocardial uptake, which means the uptake equal to or higher than the uptake of the ribs can be used for the diagnostic criterion of ATTR cardiac amyloidosis. But please remember that it should be proved that the patient does not show the serological marker of AL-type cardiac amyloidosis, because AL-type cardiac amyloidosis in some cases can show cardiac uptake. In this study, which was published in Circulation 2016, describes the false positive bone scintigraphy uptake in AL-type cardiac amyloidosis. So here, in summary, in 20%, 21% of AL-type cardiac amyloidosis shows grade 2 or more DPD cardiac uptake, and 27% can show at least grade 2 of PYP uptake. And if we see a patient with positive DPD or PYP uptake, 12% and 6% respectively of those patients can have AL-type cardiac amyloidosis. So we should additionally check the positivity of serological marker of AL-type cardiac amyloidosis, such as free light chain or some electrophoresis for the urine and serum of the immunoglobulin light chain. So The expert consensus recommendations in 2009 recommends that if there is a abnormal free light chain level, then bone scintigraphy can be rarely appropriate for the diagnosis of ATTR cardiac amyloidosis, because positive or neither positive nor negative bone scintigraphy cannot tell us that which subtype the patient should be diagnosed with. So in this diagnostic algorithm, if the patient is clinically suggestive of having cardiac amyloid, the bone scintigraphy can be performed. And additionally, the patient's serum or urine immunofixation or light chain assay should be considered to exclude the false positive finding from AL cardiac amyloidosis, which can be seen in 6 to 20%. And another recommendation is that please use the SPECT imaging if available. Here listed are the representative planar and SPECT images of the cardiac amyloidosis, TTR cardiac amyloidosis patients, and grade 2 or grade 3, which means equal to or more than REAP uptake in the heart, can be used as the marker of ATTR cardiac amyloidosis. But as you can see in this case, which we actually experienced these days recently, there can be some false positive findings due to the blood pool activity. Here on 1 hour image, we could see a little bit faint cardiac uptake here. And it was considered that the intensity was in between the uptake of the ribs and sternum probably. And on 3 hours image, the uptake went down and the uptake intensity is not as intense as that of the ribs. So the visual optic score was considered to be grade 1, and the HCl ratio, which was measured on the 1 hour image, was 1.15. And according to the ethnic practice point, this is consistent with the equivocal diagnosis for ATTR cardiac amyloidosis. So it is not helpful for clinicians to differentiate ATTR cardiac amyloidosis from other forms of cardiomyopathies. And we performed SPECT-CT images, and we could clearly prove that these activity came from the ventricular or atrial blood pool, not from the myocardium itself. So there was no myocardial uptake, and this was definitely no cardiac amyloidosis. So the clinicians could exclude the diagnosis of amyloidosis, and some more clinical workup went on to find the final diagnosis. And it is quite important to remember that the technetium MDP should not be used for ATTR cardiac amyloidosis assessment, because the sensitivity of this agent is quite inferior to the other 3 agents. So MDP is not currently included in the clinical guidelines. Please use the pyrophosphate, DPD, or HMDP only, and not MDP. Then what about the TTR gene carriers? This interesting study, which was published in Journal of Nuclear Cardiology in 2019, showed that the DPD scanning can be used for screening of the TTR gene carriers as well as the symptomatic patients. They screened the family members and the relatives of the symptomatic TTR cardiac amyloid patients. And if the technetium DPD scan was positive at baseline scan or at 2-year scan, even though the baseline scan was negative, all of the patients led to symptomatic heart failure within 2 years after the scanning. And if the patients showed a negative scan on baseline and 2-year repeated scan, no patients developed heart failure. So it is a very excellent classification of patients who are at risk of developing symptomatic heart failure in the future. So you need to do repeated bone scintigraphy in the screening of TTR gene carriers in addition to the baseline scan. So we reviewed this paper and suggested the clinical assessment algorithm, as you can see here. If there is an asymptomatic TTR gene mutation carrier, we perform the bone scintigraphy. And if there is positive cardiac uptake, the patient will probably develop symptomatic heart failure within a very short time, median 2 years. So we should consider preventive treatment, probably tafamidis these days. And even if the scan is negative, we should do the repeated scan at 2 years. And then if the scan is positive, also we can consider preventive treatment. But if the scan is negative on the follow-up 2-year scan, then we can suggest that this patient has low risk of cardiac amyloidosis development within a short period of time. So the current expert consensus also included this screening as the appropriate use of the bone scintigraphy in asymptomatic TTR gene carriers. So please remember that for initial evaluation and also for recurrent testing, the bone scintigraphy can be used appropriately in the family members or relatives of the patients who actually have TTR cardiac amyloidosis. This is the end of my presentation, and thank you very much for participating and paying attention for my presentation. Thank you.
Thank you, Sang-Geon. Do any people have questions or comments for the lecture? I would like to ask one for interpretation of our myocardial perfusion imaging, maybe. So from the criteria you have shown previous in the lecture, I think it was about recommendation for revascularization is for if there is a severe or extensive ischemia. So is there some consideration not only for the extent of the ischemia, but also like severity of the, so like is there some clinical significance when we interpret our perfusion image as like mild or moderate or severe defect or decrease? Is there some significance to interpret like that?
Thank you for your very important question. Actually, that recommendation takes into account both extent and the severity of perfusion defect. When we semi-quantify the perfusion abnormality on myocardial perfusion spec or even PET, we generally use the sum stress score, sum rest score, and sum difference score. And the 10% threshold of 10% means the percentage of some difference score to the total, the highest some difference score that can be obtained. So if we use 17 segment model and the highest SDS we can get is 68 points. So if we have SDS of 7 points, then we can recommend the revascularization strictly according to the guideline. However, if the when we have much less extensive or severe ischemia, we can also mention that there is a small mild degree or moderate degree of ischemia, because if the patient is symptomatic and when the symptom is refractory to medical treatment, then revascularization can be performed only to improve the patient's symptoms. So it is not meaningless even when we see some mild or moderate ischemia only.
Thank you very much. Would there be other questions or comments?
Good morning, Prof. Thank you for the lecture. I'm Nora from Hasan Sadikin Hospital, Bandung. I want to ask something. Why is nuclear medicine is not recommended to evaluate the infective endocarditis with native valve? And why is it only recommended for prosthetic valve? Thank you.
Okay, your question is about why the nuclear imaging is not recommended for native valve. Is that right?
Yeah, yes, that's right.
Okay, in the studies evaluating FDG PET or other WBC SPECT CT, the diagnostic accuracy was quite better for FDG PET as compared to other echocardiography or other imaging modalities, especially in prosthetic valve endocarditis. And in the native valve endocarditis, it is not, it is quite clear then that the echocardiography can play an important role in the final diagnosis without biopsy of the vegetation. So actually FDG PET or WBC SPECT CT is not the first line imaging modality, but the second line imaging modality. So when the other conventional imaging modality shows equivocal results, then we additionally perform nuclear imaging modalities, FDG PET or WBC SPECT CT. So that's why in the native valve endocarditis, where echocardiography is sufficient, nuclear imaging is not generally recommended.
Okay, thank you, Prof. So actually, PET FDG still can diagnose from the native valve, but because of the conventional diagnostic tools is already can get the diagnosis, so we didn't need to do the nuclear imaging.
Yeah, I think you're correct.
Oh, okay. Thank you, Prof.
Good morning, Prof.
Nice to meet you.
Good morning, Prof.
Yeah, I hear you.
Yeah, I'm Rian, resident medicine resident in Hasan Sadikin Hospital in Bandung, Prof. I would like to know about the DPD. Before in slide you say about in patient with light chain amyloidosis for background uptake higher than patient with FUTR or control. Why like that, Prof? Thank you.
I'm not sure if I understood your question correctly.
Okay.
So the question is about
DPD.
the use of DPD in the diagnosis of cardiac amyloid?
Yeah, transthyretin amyloid doses.
Okay, I
Because
will.
in before you say about the in patient with light chain amyloidosis have background higher for the background uptake. Yeah, this one
Mhm.
in AL.
Why can't we
AL.
see the uptake in AL type? Is that your
Yeah,
question?
yeah. Yeah.
All right.
Why background
Mhm.
uptake is higher?
It is not clear, but some researchers think that it is the difference in the pathological characteristics of the cardiac involvement between TTR and AL cardiac amyloidosis. In the cardiac MR studies, TTR cardiac amyloidosis shows more extensive late gadolinium enhancement, which represents the myocardial necrosis and fibrotic scar, and the uptake of bone scan agents is also based on the myocardial necrosis and dystrophic calcification. So maybe the more extensive myocardial necrosis, dystrophic calcification probably led to more intensive bone scintigraphy uptake in the TTR patients as compared to AL type. But the the precise pathophysiology underlying the differences in the uptake is not clearly known so far.
Okay, thank you, Prof. Maybe for the next question about still DPD. If we have patient with equivocal uptake in DPD, what next? What we should we do? What should we do after that? If equivocal uptake to confirmation the diagnosis.
You mean the focal cardiac uptake?
Yeah.
Okay.
Equivocal uptake. I mean grade 1 like that.
Grade 1 uptake.
Yeah, grade 1.
Grade 1 uptake is equivocal for diagnosis ATTR cardiac amyloidosis. So in the guidelines, they recommend further image testing or endomyocardial biopsy according to the local expertise and availability of the imaging modalities. So in equivocal cases, the patient's history and other image findings and patient's disease progression course, everything should be considered to differentiate the patient's patient subtype. So when it is equivocal, it is quite challenging for clinicians. So that's why I recommend you to use SPECT-CT in such cases. Then there were some studies evaluating the value of SPECT-CT in patients with equivocal bone scintigraphy findings, but I'm not clear it has already been published as a paper. Maybe I will have to take a look.
Thank you, Prof. Maybe for the last question. Actually, I already asked this question yesterday, but still didn't get the answer about the MDP. Why is not appropriate to diagnose patient with ATTR?
There were some reports indicating the suboptimal sensitivity of technetium MDP, but the real cause is not known. But anyway, it is not as sensitive as the other bone scan agents. So please don't use MDP in the cardiac amyloidosis workup.
Is there any different mechanism for uptake between MDP or DPD, MDP, and PYP? in amyloidosis TTR?
Well, I have no
In-
experiences in DPD, but some experiences in HMDP and some more experiences in PYP. And I think PYP is quite good. And some doctors say that DPD is probably the best. But in our institution, we chose PYP because the clinical practice point, which was published by ASNIC, was the clearest guide to make readings to the clinicians, and it is very clearly summarized for reporting in the clinical setting. So we can, in quantitative manner, we can give diagnostic category as strongly suggestive and not suggestive of TTR cardiac amyloidosis. And when the HCl ratio is between 1 and 1.5, then we can suggest it equivocal. And it was so clear, and it was very practical. So that's why we chose PYP. But I guess although some say that DPD may be better than PYP, but I think PYP can be sufficient for clinical use.
Thank you very much, Prof. Good morning.
Thank you.
Dr. Zhou, I have one question regarding the microvascular angina, the clinical trial. So in the slide there, they compare the intervention group and the control group. So is the intervention group meaning of giving some appropriate drug, or compared to not doing any kind of treatment for the control group, or is it doing? So what's the meaning of intervention in this here? Sorry, I think I have missed your explanation for it.
Actually, it was also difficult for me to understand all the selection of medical treatments in such patients. They used the expression of medical treatment stratification. So they used first line, second line medical therapies, which was consisted of some different vasodilator medications and some risk factor modifiers. I could not remember the detailed medicine, the names of the medicine on this presentation, but they used the expression of stratification of medical treatment. So probably there was a certain difference in the medicine prescription according to the functional testing.
So I think they're like doing some intervention, like picking out some patient with microvascular angina may be important, and I think like functional imaging can do that. But is there real some like trials or studies that have really seen that this functional imaging can actually can see the microvascular angina, or is there some studies regarding that?
Actually, in this CORE-MICA trial, they measured the invasive markers of microvascular angina, including CFR or IMR. And actually, there is no currently available whole marker of microvascular disease. Even the invasive markers are not fully dedicated for microvascular disease, and non-invasive imaging such as PET cannot clearly delineate the pure microvascular disease. So any marker can be used. Even there is a very cruel marker for microvascular disease, such as using PET decreased CFR without perfusion defect was also used as the marker of microvascular disease, but many interventionists and even I don't agree with that definition. So the picking up the patients with microvascular disease is still under controversies. So maybe it should be coming up from the doctor's expertise using probably invasive and non-invasive modalities at the same time, but I'm not sure which marker will really work.
Thank you very much. So if there is no more questions or comments, I would, on behalf of every participant, I would like to thank Professor Sang-Geon again, and thank you very much. And yes, so we will end this session now. Thank you very much.
Thank you. Have a nice day.
Thank you, Professor Sang-Geon. Warm regards from Indonesia. This is Erwin.
Oh, hi. Nice to meet you again, Orin.
Yes. I hope you still recognize me. Okay, goodbye. Thank you, Prof. Sang-Geon.
Of course I do.
Your last visit to Jogja, yeah, right? With from Singapore. Pushan.
Yeah. Is he here?
Yeah. No. I already invited him, but I
Oh.
think his work.
Yeah.
Okay. Thank you.
Thank
See
you.
you later. Okay. Thank you. Bye.
Hope we meet again.
Okay.